So in this second part of the lecture on endocrine system, we are going to look at two major glands, thyroid gland and parathyroid gland. But we'll also look at the hormones which regulate calcium metabolism. Remember what we agreed on in the first part concerning our learning outcome, that for each endocrine gland, you need to know where it's found, the location, and you need to be able to describe the gross anatomical parts of that gland. Then after doing that, we need to state the major cell types of the parenchyma of that gland, the cell types which produce hormones, and then indicate the hormones they actually do produce. And for those hormones, we then need to know where they act, that's the target organ. And we also need to know the physiological effects of those hormones on their target organ. And lastly, because we are clinicians, we need to highlight some clinical disorders related to abnormal levels of these hormones. So that's what we'll do still when we're here. Let's look at the thyroid gland itself. Okay. So thyroid gland is located in the anterior lower neck, just in front of your trachea. That's where the thyroid gland is found. Anterior lower neck in front of the trachea. This is the gland, that's the trachea. You notice that the gland has two lateral lobes, the right lateral lobe and the left lateral lobe. And that the two lateral lobes are joined by this narrow region, which we call the isthmus of the thyroid gland. The parenchyma of this gland, which means from at histological level inside, the parenchyma of the gland has some things we call follicles. These follicles are of varying sizes. This is how they look like histologically. That's a big one, that's a small one, that's a small one. They are follicles of different sizes. I'm going to show you how the follicles look like shortly in the next slide. These follicles are the ones which actually secrete and store the thyroid hormones. The follicles are surrounded, or rather are made up of two things. We have this central material, which we call the colloid, and a ring of follicular cells around. So the first cell type we're talking about are the follicular cells, these ones here, which surround the colloid. But between the follicles, we have other cells, which we call parafollicular cells. So that the parenchymal cell types are the follicular and parafollicular cells. These are the cells which secrete hormones. The thyroid hormones themselves are stored within the colloid. Colloid material contain thyroglobulin, which is the storage form of thyroid hormones. Let's look at thyroid gland from a histological perspective. So in this image, this is the slide of thyroid gland. Maybe in this magnification, we are not able to see the gland itself and be certain that's actually thyroid gland. But there's something I want to capture in this low magnification before I give you higher magnification. We see that the organ we are looking at is surrounded by a connective tissue capsule. So the thyroid gland is encapsulated. If I give you a high magnification of that, what do we notice? Yes, there's that capsule, which is a connective tissue capsule. But we notice that this capsule actually sends in some connective tissue septa or trabecula into the gland. Look at that region. That's part of the capsule, but we see some connective tissue extensions into the gland. So these connective tissue extensions into the gland are connective tissue trabeculae, which tend to divide the gland into some lobules. So remember, there are two lateral lobes. Now there are smaller lobules, like these are smaller lobule. That's another smaller lobule. We can see the connective tissue trabeculae within the gland. Apart from the trabecula dividing the gland into lobules, the trabecula serve very important functions. Of course, they contribute the structural integrity of the gland, so they hold the gland. They're the supporting framework for the gland. But they also carry blood vessels. Look at this region. That's a blood vessel. That's a blood vessel. That's a blood vessel, most likely even that one. So the trabeculae contain blood vessels. Good. So that is more about the stromal tissue, the connective tissue elements of the thyroid gland, the connective tissue capsule, and the trabeculae. These trabeculae contain blood vessels. That is the supporting framework. Now let's look at each of the lobules and see what the parenchyma of the thyroid gland is made up of. Remember, a gland will have a stroma and a parenchyma. The stroma is the connective tissue part. The parenchyma is the functional part. Now, let's look at the functional part, and I'll use this high magnification to show us the functional part. So the parenchyma of the thyroid gland consists of secretory follicles. That's a follicle, that's a follicle, that's a follicle. And what do we notice about the follicles? Each follicle consists of a central homogeneous material, which we call colloid, and a ring of simple cuboidal or simple columnar epithelium. That rim of simple cuboidal, simple columnar epithelium constitute the rim of follicular cells. So each follicle consists of colloid surrounded by follicular cells. They are follicles of varying sizes, but the follicles are either spherical or ovoid of varying sizes. Look at that one, a bit large, that's a bit small. That's what I'm talking about. That is what the parenchyma is made up of, but still talking about the parenchyma. Look at this one. That is a single follicle. That's the colloid material. So take note, the cells that surround the thyroid follicles are called follicular cells. These are the cells which surround the colloid. We call them follicular cells. In between the follicles, there is something. So between this follicle and that follicle, there'll be something. Look at this image. We see some trabecula still. Very thin though, but that's still present. And this trabecula contain capillaries, like that one's a capillary. But let me use this other one. So these are capillaries. The thyroid gland is heavily vascularized because it's an endocrine gland. Between the follicles, we have the capillaries. But what else do we have between the follicles? Between the follicles, there are some cells that are also present. Look at the one pointed. The one pointed is not surrounding any follicle or that region. Look at that region. They're not surrounding any follicle, but they're between the follicles. The cells of the thyroid parenchyma that do not surround the follicle, but are between follicles, are known as parafollicular cells. Even this field, those are parafollicular cells. That's a follicle, that's a follicle, that's a follicle, but that's parafollicular cell. There are cells which do not surround the colloid. They are in between the follicles. Parafollicular cells also produce some hormone. Good. So that's the histology of the thyroid gland. When the gland is active, that means that the follicles are producing the thyroid hormones. The cells, the follicular cells, will be of this nature. They'll be columnar cells, and maybe they have some microvilli. And the colloid material will be very minimal. Those are features of an active thyroid gland. But when the gland is not active, the follicular cells are cuboidal or low columnar, and the amount of colloid material is abundant. So this one is the inactive state, and this is the active state of the thyroid gland. These are the images also show you the inactive and the active state of the thyroid gland. Remember, the colloid material is the storage form of the thyroid hormones, which we call T3 and T4. Good. So this is where we are. In terms of anatomical location, we've talked about its location: anterior neck in front of the trachea. In terms of the gross anatomical parts, 2 lateral lobes and an isthmus. The functional cell types are follicular and parafollicular cells. The follicular cells produce 2 hormones, T3 and T4. T3 is called triiodothyronine, and T4 is called thyroxine. The targets of these hormones is basically all cells in the body, and usually T3 and T4 modify the basal metabolic rate. Now, from the thyroid gland, the major hormone produced is actually T4 in abundance and T3 little, but they're both produced. However, at the tissue level, T3 is the most active. So what usually happens is that T4 thyroxine is converted to T3 triiodothyronine, but that conversion occurs in the peripheral circulation once the hormones have been released from the thyroid gland. T3 can still be produced by the thyroid gland directly, and it acts on cells. But thyroid gland produces more of T4 than T3. Then T4 will be converted to T3. Again, not necessarily that all T4 will be converted to T3 in the circulation, and T4 can also still act on the cells. So both of them act, but the active form is T3, the produced form is T4 predominantly. So there are many effects of thyroid hormone T3 and T4 on different organs, on different systems. I've just picked a few to capture the effects so that when we have abnormalities of thyroid gland, you know how these ones are affected. For example, in the heart, the thyroid glands the thyroid hormones will increase the heart rate, and that is what we call the positive chronotropic effect, increasing the heart rate. It also increases the force of contraction. That's what we call positive inotropic effect. The mechanisms are many, but that's what it does on the heart. On adipose tissue, it's catabolic. Basically, it stimulates breakdown of fat. On muscle, it's also catabolic. Usually increase breakdown of protein in muscle. On embryology, thyroid hormones are also very important during development. It promotes the normal growth of all body cells, generally, but also of the skeletal system. Very important. In the nervous system, again, it's important for normal brain development. Remember, this is fetal, but again, continue even to childhood, normal development. In the GIT, thyroid glands are metabolic, increase the rate of carbohydrate absorption or carbohydrate utility. It also promote the formation of low-density lipoprotein receptors. And there are many other effects of thyroid gland in other tissues, but basically, generally calorigenic, which means that develop more calories, basically. So if you look at that, we can say that increases the basal metabolic rate in those tissues. It also helps in increasing oxygen consumption by a number of active tissues, but there are a few exceptions. So anyway, summarize and say that thyroid gland hormones T3 and T4 promote metabolism. There's some anatomical disorders of the thyroid gland that I want you to be familiar with. The gland may be abnormally enlarged. The term given for an abnormally enlarged thyroid gland is called goiter. Now, goiter does not tell us whether the gland is producing a lot of hormones or less hormones. The term goiter simply means enlarged thyroid gland. And an enlarged thyroid gland may be hyperactive, so it may be having hyperthyroidism or may be hypoactive. It depends on the cause of the enlargement. Some people may have thyroid gland not in the neck, as we've mentioned, but somewhere in the thorax behind the sternum. We call that retrosternal thyroid. Now, this is a developmental disorder of the thyroid gland where it becomes stationed behind the sternum. It may also be in the tongue, in which case we call it lingual thyroid gland. So the concept is that you can have ectopic thyroid gland, and retrosternal thyroid is just one of the examples. Now, remember that thyroid gland is being instructed by pituitary gland, but pituitary gland was instructed by hypothalamus. Now, let's look at that hormonal axis. Hypothalamo-hypophyseal-thyroid hormonal axis. We mentioned that hypothalamus produces a hormone which goes to the adenohypophysis, and that hormone is called thyrotropin-releasing hormone. Thyrotropin-releasing hormone travels through the hypothalamo-hypophyseal portal system to go to the anterior pituitary gland, adenohypophysis. It acts on the thyrotrophs, which are a type of basophils within the adenohypophysis. And the physiological effect is to stimulate production of thyroid-stimulating hormone. Don't confuse thyrotropin-releasing hormone with thyroid-stimulating hormone, TSH. So TSH is also known as thyrotropin itself. This is thyrotropin-releasing hormone, but this is thyrotropin. So thyrotropin acts on the follicular cells of thyroid gland, and the effect is to promote production of thyroxine T4, or you can call it tetraiodothyronine, and T3 triiodothyronine. We've talked about the physiological effects of these hormones. Good. Now let's talk about thyroid disorders. The image is shown to you here, or rather, what you're seeing here are laboratory results or possible laboratory results of some patients with perhaps thyroid disease. And so one of the things that need to be checked is the levels of hormones. And routinely, you check the levels of TSH and the levels of T3 or T4. There are others that you can also check. The arrow looking down means that the level is low, and the arrow facing up means that the levels are high. So for example, patient A has low levels of TSH and high levels of T3, T4. Patient B has low levels of TSH and low levels of T3, T4. That is patient C, high, high, and patient D, high, low. I want us to give some names to the diagnosis that we are seeing here. This is how we classify thyroid disease. We base it on the concentration of T3 and T4, the levels of T3 and T4. So, if the levels of T3 and T4 are elevated, we call that hyperthyroidism. And if the levels of T3 and T4 in the circulation are low, we call that hypothyroidism. So get that first. And then we can classify whether this thyroid disease is primary or secondary. A primary thyroid disease is a disorder that is intrinsic to the gland. A secondary thyroid disease is a disorder related to either hypothalamus or pituitary gland. It's a problem with the stimulation of the gland. So look at patient A once again and tell me, if someone has low levels of TSH and high levels of T3, T4, is that hyperthyroidism or hypothyroidism? And if it is whatever, is it primary hyperthyroidism or secondary hyperthyroidism? Is it primary hypothyroidism or secondary hypothyroidism? Okay, make a decision before I tell you. So patient A has primary hyperthyroidism because high levels of T3 and T4 are being seen, so it's hyperthyroidism. But we see TSH is low, which means this hyperthyroidism is not being caused by stimulation. The gland is just hyperactive. Patient B has secondary hypothyroidism because we see low levels of T3, T4, and this is as a result of understimulation. Patient C has secondary hyperthyroidism, high levels of T3 and T4 because of overstimulation. And patient D has primary hypothyroidism. We see that it's being overstimulated, but there's no response. So this gland is hypoactive. Now, there's also this one where patient has normal levels of TSH, but high levels of T3 and T4. Think about it. So that is primary hyperthyroidism. The gland is intrinsically hyperactive, even with normal TSH levels. There's another one. The last patient there. Again, think about it. Is it hypothyroidism or hyperthyroidism? Now, this patient, if you look at it, we are saying that we have normal levels of T3 and T4. As long as you have normal levels of T3 and T4, we cannot say it's hyperthyroidism or hypothyroidism. So this is normal T3, T4 levels. The term given to this one is euthyroidism, euthyroidism. So this is euthyroidism. It is not hypothyroidism or hyperthyroidism. But I agree with you that this gland is not normal. The situation is not normal here. Most likely, this gland can actually be hypothyroidic because it requires a lot of stimulation for it to have the normal response. So it's possible that the gland is potentially hypofunctioning. But at this point, this is euthyroidism. Great. So we've talked about the follicular cells and the hormones produced by the follicular cells. The other cell type of the thyroid gland are parafollicular cells. Parafollicular cells produce calcitonin hormone. Calcitonin acts on bone tissue, and the effect of calcitonin on bone tissue is to inhibit bone resorption. That will affect calcium levels. We'll be talking about hormones that affect calcium levels. Now let's talk about another gland. That is the parathyroid gland. Look at this image. The surrounding here is actually thyroid gland. You can see follicles of different varying sizes. Then there's this organ here. That's a parathyroid gland that we want to talk about. In this image, this is the thyroid gland. We've already talked about that histology, so we understand. Then there's that one, which we call parathyroid gland. There are 4 parathyroid glands usually. There are 4 ovoid glands located behind the lobes of thyroid gland. So these 2 are called the superior parathyroid glands, and these 2 are called the inferior parathyroid glands. We'll not say much about the gross anatomical part. There's nothing much to say, but the key cell types which are within here are called the chief cells or the principal cells. And these are the cells which produce the hormone, parathyroid hormone, also known as PTH. This hormone targets bone tissue and kidneys, and it influences calcium metabolism. Let's look at the histology of the parathyroid gland first. So the image you have here is the image of thyroid gland. We see thyroid follicles of varying sizes. We see the connective tissue, the blood vessels, and the trabeculae. This is high magnification. Again, you're still seeing the thyroid gland. Different follicles, varying sizes. Even that one. And perhaps here you also see the parafollicular cells as well. That's a capsule. Now, next to that, we see this ovoid structure, which is also encapsulated. So this hypercellular ovoid structure adjacent to the thyroid gland is the parathyroid gland. It's hypercellular, the cells are in cluster. It's ovoid and encapsulated. You can see a thin capsule there. Maybe this magnification shows you that capsule better. This is the capsule of the parathyroid gland. So this is parathyroid gland, this is thyroid gland. I want to magnify this one further. So in this field, we see the cells of the parathyroid gland, and I want us to name all of them. There are some cells that look like this. That one, that one, that one, these ones. You've seen them now. They're the largest cells. These cells don't seem to have content of the cytoplasm at view. Now, this because it doesn't mean that they're lacking, but it's because the cytoplasm contains fat. So these are adipocytes. They are scattered fat cells. Adipocytes are fat cells. Those are the first cells that we are talking about, the adipocytes, scattered fat cells. The second cell type we are seeing are these ones here. They're also large. Their cytoplasm is deeply staining, as we can see, and they're large cells, these ones or these ones. We call these ones oxyphil cells. Oxyphil cells. So there are also many, but not as many. You can see that one, even that one is another one. Oxyphil cells. They are large, and their cytoplasm pick up stain. The third cell type are these ones here. Look in this group. We see a cluster of cells with clear cytoplasm. They're smaller than the ones you've just seen. They have clear cytoplasm, like that cell. You see a nucleus and clear cytoplasm. These ones are called clear cells. Clear cells. They exist in cluster. The last cell type are these ones here. They also exist in cluster. So these ones, their cytoplasm are picking up stain. They're tiny cells, they're in cluster, and their cytoplasm pick up the stain. These are the ones we call the chief cells or the principal cells. These ones are the ones which produce parathyroid hormone, PTH. So I've taught you 4 cell types. The fat cells, adipocytes, oxyphil cells, clear cells, and principal cells or chief cells. The chief cells are the majority, and they're the ones that produce the hormone. Now, parathyroid hormone control calcium metabolism, as I've told you. Now, let's look at metabolism of calcium before I tell you the hormones that, summarize for you the hormones that control calcium metabolism. So we can get calcium from the diet. So when you eat, that goes to the GIT. Of course, there'll be that which the body will be able to absorb, and there'll be that which will not be absorbed. So let's think about the one that the body absorbs. The one that the body absorbs goes to the extracellular fluid circulation. So it is in the bloodstream and the like. When it is in the bloodstream, it can be exchanged with the bone. So calcium, which is in the bloodstream, can go to bone tissue and back. And it's that those that is easily exchanged, and that those calcium that is almost stable within bone. The calcium that is stable within bone is quite a lot. And so bone tissue is the storage form of calcium. Or let me say that in a different way. Calcium is stored within bone matrix. But there's that can be exchanged, fine, depending on some circumstances. Again, from the bloodstream, calcium goes to the kidney, and that can be excreted in urine. But again, we know that the renal tubules also reabsorb calcium in the presence of some hormones. So basically, this is how calcium circulates within the body. So which hormones regulate calcium metabolism? Parathyroid hormone, which is from the principal cells of the parathyroid gland, affect calcium metabolism this way. One, it promotes bone resorption. That means that bone releases the calcium into the bloodstream. It also reduces the loss of calcium in urine. That means that calcium becomes recycled to the bloodstream. Those two mechanisms, if you realize, they lead to increasing the levels of serum calcium. So the take-home message is that parathyroid hormone elevates serum calcium levels. The other mechanisms that it operates with, promoting the formation of vitamin D, and we're going to see how vitamin D affects calcium metabolism shortly. Well, parathyroid hormone also has an effect on the phosphate. It promotes renal loss of phosphate. The other hormone that affects calcium metabolism is calcitonin. This is from the parafollicular cells of thyroid gland. Calcitonin inhibits the activity of osteoclasts. Remember, osteoclasts are the cells which break down bone. They are the cells that cause bone resorption. So if calcitonin inhibits the activity of osteoclasts, that means that calcitonin inhibits bone resorption. And if it inhibits bone resorption, it means that calcium will be held on bone tissue as opposed to being released to the bloodstream. That mechanism will suppress the levels of serum calcium. The other mechanism it operates with is to increase the excretion of calcium in urine. Again, that will also suppress the levels of serum calcium. So take-home message there is that calcitonin lowers the levels of serum calcium. Remember, parathyroid hormone elevates. The third hormone is vitamin D. Vitamin D increases the absorption of calcium from the intestines into the bloodstream. So that will increase the levels of serum calcium. Vitamin D also promotes bone resorption, just like parathyroid hormone. So again, that will also increase serum calcium levels. And importantly, vitamin D reduces the loss of calcium in urine. So again, that will elevate the levels of serum calcium. So take home, vitamin D increases serum calcium levels. Think through this. Suppose the levels of calcium in blood go down. What happens? A decrease in the levels of serum calcium will trigger the parathyroid glands to produce parathyroid hormone. Once we have the parathyroid hormone in the circulation, it will act on bone to promote bone resorption. So if there is bone resorption, it means that calcium will be released from bone to the plasma, and that will then help to restore. The low levels will now be normal. Parathyroid hormone also acts on the kidney to increase the reabsorption of calcium. If it increases the reabsorption of calcium from the kidney, it means that the urine will have less calcium. And so that will help to also restore the plasma calcium levels to normal. Parathyroid hormone also help in the activation of vitamin D in the kidney. Remember, vitamin D is active in the kidney. I'm going to show that shortly. But because of that, therefore, the levels of vitamin D will be elevated. And we know that vitamin D promotes the absorption of calcium from the intestine. So that will also help in restoring serum calcium levels. Good. Let's finish with this one. the pathways of vitamin D. We get vitamin D either from what we eat or from metabolism in the skin. Whether it's from skin metabolism or from what we've eaten, the form of vitamin D that we get in our circulation is not active. It's the inactive form of vitamin D. This inactive form of vitamin D goes to the liver so that the liver metabolizes it. What the liver gets out is still not active form. It's an intermediate form of vitamin D. We call it calcidiol. So remember, it's not the active form per se. This inactive form of vitamin D, the intermediate metabolite of vitamin D, calcidiol, is the one that is activated in the kidney. And so this is where parathyroid hormone acts, so that it can activate vitamin D. The active form of vitamin D is called calcitriol. Well, from the kidney metabolism, we'll have calcitriol, but we'll also have some inactive metabolites. So this calcitriol is the active form of vitamin D that acts to cause the effects that we just mentioned. Great. So that's the end of that lecture, that second part on endocrine system, where we've talked about thyroid, parathyroid, and we've also talked about hormones that affect calcium metabolism. So we'll stop there. Our next topic will be on adrenal gland, pancreatic islets of Langerhans, and the gonadal hormones. Thank you very much. We'll stop there.